Hello, welcome. I'm Dr. Karen Fowler, a professor of pediatrics in the Division of Pediatric Infectious Disease at the Heersing School of Medicine at the University of Alabama in Birmingham. Welcome to our program entitled Vaccination Success Stories on the Road to Congenital CMV Prevention. I'm honored to have joining with me today Dr. Sallie Permar, who is a professor and the chair of the Department of Pediatrics at Weill Cornell Medicine in New York City. And I'm also excited to have Amanda Devereaux with us, who's a nurse and also program director of the National CMV Foundation. And also Amanda is very specially someone we want on this program because she's a CMV mom. So we look forward to hearing. So I'm going to just get us going because I know we don't have much time, Amanda, but I'd really like for you to talk a little bit about why is congenital CMV a public health concern?
Yeah, happy to be here. Thanks so much for hosting us here, Karen. CMV is an important public health concern because it causes a lot of birth defects and health conditions in children. And really, it's prevalent worldwide. It's common. Lots of people get infected with this and don't even know it. And the prevalence is different in different countries across the world. But in the United States, about 1 in 3 children are infected by the age of 5, and about 50% or more of adults are infected by the age of 40. And so when we look at the number of infants who are actually born with CMV, it's about 1 in 200 babies are born with the virus. And so that's a lot of babies that have the potential to have a birth defect or a health condition. And so when we look at the number of children in the United States who have long-term health consequences from different disorders, congenital CMV is actually one of the most common causes of those health conditions in children, similar to the number of children each year who are impacted by Down syndrome, and quite a lot more than some of the other disorders that people are aware of, spina bifida or even rubella, much more common than those. And so if we look at what are the consequences of congenital CMV for children, they're really varied. And so we can have children who are born with hardly any symptoms at all, and they will pretty much stay asymptomatic their entire lives. And so we have that on one end of the spectrum. And then we have all the way to children who are pretty symptomatic, and maybe even people will have a miscarriage or a stillbirth, or the infant will die, or the child will die in the first few years of life. And then we have everything in between. And so one of the most common things we see in these children is hearing loss. And so these children may use hearing aids, cochlear implants, sign language, different ways to address that concern. There's also developmental delays, cognitive delays, feeding issues. Vision loss is also something that happens with congenital CMV. And but it's really varied. And so most children are actually going to be born with no obvious symptoms. Actually, the vast majority, maybe 90% of children who are born with CMV won't have symptoms that are apparent at birth. And then another interesting thing that we're just really starting to understand is that CMV may be linked with autism. So that's something that is an area of ongoing research. And it's important to note that all pregnant women are at risk for CMV. Even if they've had CMV before, that doesn't provide full protection. And so that's something that sometimes we still hear from people is, well, I've probably had it, so it's not something I need to worry about. And actually, worldwide, most infants who are born with CMV are born to moms who'd already had a CMV infection before. So it's important, something that most everybody needs to know about, but unfortunately only about 9% of women are aware of it.
Wow. Yeah. I mean, it causes so many ill effects or bad effects for the infants, and then for women not to even know about it. It's real concern. So that leads us to, Sallie, I'd like to get your ideas on, let's talk a little bit about vaccination, right? So what are the advantages and challenges of vaccinating prior to pregnancy?
Right. So as Amanda and you highlighted, this is a disease or an infection that needs a vaccine. And in fact, the whole community has been working on a vaccine for over 60 years. And so it really is beyond time for us to have a vaccine for this very common yet devastating infection for children. So a leading cause of birth defects and developmental disabilities and hearing loss is caused by just one virus. In fact, the majority of hearing loss can be contributed to this virus that occurs in infancy, even compared to all the genetic causes. So that's why it has been ranked as a top priority by the National Academy of Medicine. And right now we don't have adequate way to prevent it or even treat an infection in a mom that might reduce the chance of infection in the baby. What we have now is an antiviral that can be provided to an infant if they are diagnosed with CMV and if they have true nervous system, central nervous system effects that indicate that there will be some benefit from the antiviral. So it's a disease that does not have prevention, does not have adequate treatments, and really the best way to eliminate this as a cause of delays and birth defects in children is to have a vaccine. Now, when to vaccinate is a big question here that we talk about a lot. As many of us know, you often don't know that a person is pregnant, or a person may not know that they're pregnant until several weeks into the pregnancy. And that's actually a critical time when, if you acquired CMV for the first time or even acquired it again in that early pregnancy period, that could be a damaging infection to the fetus. So the vaccination really will have to occur prior to pregnancy. And that means that we're talking about before women are sexually active, even. So thinking about adolescence. But a challenge that we have is that our adolescent population doesn't have as high an uptake of vaccines as, say, our infants under the age 5, where we're very good at adhering to a pediatric vaccine schedule. There is some thought that there may be some advantages to moving the vaccine even earlier. Toddlers are actually the ones who spread a lot of this virus because it's spread through saliva and through other body fluids like urine, stool. And so toddlers are a big source, and they can pass it on to their parents and their mother who may be pregnant. So there is some thought that maybe that will be a target population for vaccines. But at this point, most of the vaccines are being tested in a way that would be utilized for either adolescents or early young adults.
Right. So taking this a little bit further about the timing of vaccine and what are the implications for fetal health?
Yeah, so one thing that because of how the population that we see that will be included in the vaccine will be an adolescent population, it really will be pediatricians who are on the front line of offering this vaccine once we have an approved product. And that is actually could be an advantage for this vaccine because pediatricians are the ones that are also on the front line of seeing the negative impacts of this congenital infection on the babies. The obstetricians, while that's when the infection may happen, they often don't see the consequences in the babies because sometimes it's not diagnosed right away. It's not diagnosed right around birth. So pediatricians, I think, are going to be armed with the right experience and knowledge and understanding of how important this infection is to eliminate from getting it during pregnancy, that they will be motivated to immunize adolescents. However, even pediatricians who are very good at promoting vaccines still have a hard time getting their adolescents on a strict vaccine schedule and completing all their vaccines. Think about HPV as one that doesn't have as high of uptake for such an amazing anti-cancer vaccine that it is. So, but it's something that pediatricians need to start thinking about because a vaccine has the possibility of being licensed even in the next year or two. And we need our OB colleagues and our other medicine colleagues to start promoting the importance of this, since the patients that could become infected after the adolescent period are their patients too.
Right, right. So it seems really important that we explore that. And since I've got Sallie as an expert here, I'm going to ask her some more questions before she gets away from us. So what are some of the lessons that we've learned from prior vaccines that are intent on protecting the fetus? Is there anything we can learn from those?
Absolutely. So the model that we want a CMV vaccine and any other congenital infection vaccine to emulate would be the rubella vaccine. The rubella vaccine has been a global success story. where in any country that uses the rubella vaccine, which is the R in MMR, in early childhood, so often it's given around 1 year of age, that is a vaccine that achieves protection lifelong, including during pregnancy, when rubella was the biggest concern. If you became infected with rubella for the first time during pregnancy, you had a risk of passing it to the fetus, and the fetus could have birth defects, brain damage, heart disease, etc. So everywhere the vaccine is rolled out and has good uptake, essentially has eliminated congenital rubella from a disease that we even see anymore. And that is what we want to achieve with a congenital CMV vaccine. In fact, I've heard some of my mentors who were around in the days when the MMR vaccine first started to be used, they talk about how the schools for the deaf and blind had to close because there were not enough children to enter them anymore. And that's really what could be achieved with a CMV vaccine. So that's a vaccine we give in early life for protection during pregnancy. We had the recent rollout of the RSV vaccines, both a pregnancy vaccine that is designed to improve the maternal antibody that's passed on to the baby via the placenta, as well as a passive vaccine that was available for infants at birth or who are still young when the RSV season comes around. I think what we learned from that is that, again, takes a team, that the education about the risks of an RSV infection in an infant needs to start in pregnancy, and even promotion of the vaccine, but also that pediatricians were really excited about implementing this vaccine and giving it to their patients. And in fact, the company that rolled out the infant version of the vaccine completely underestimated the demand for this vaccine. And so I see that could also be a pattern with the congenital CMV vaccine, that many pediatricians are excited about giving it, but we also have to make sure our patients are aware that this is a problem and why they want their adolescent or as a young adult, they want this vaccine to protect their pregnancy.
Thanks. Right. So, I mean, wouldn't it be incredible if we could sit here in a year or two, or it'd probably be a little bit longer than that, but still, and say CMV went the way of congenital rubella? Like, we don't see it. That would be incredible. Mm-hmm. So, on that note, Sallie, I'm not letting you get away yet because you're my expert. So, where are we now in vaccine development for congenital CMV?
Yeah, it's a super exciting time for congenital CMV vaccine development. And that's because there are a lot of different products that are in human studies. And for the very first time in all of history, we have a phase 3 trial of a CMV vaccine that is currently being led by a product from Moderna. That's an mRNA vaccine that has 2 components of the CMV virus, a protein called glycoprotein B and a protein called the pentameric complex, or actually that's a complex of 5 proteins. That is one that they actually started studying well before COVID was even on the radar. And so this is one that has been tested for even longer than the COVID vaccine. That is fully enrolled, and really we're going to be awaiting a result the rest of this year, maybe into early next year. Another vaccine that has been tested in humans is what's called the V160 vaccine, which is a infectious virus, but only can achieve 1 infection. And that means it is safe. It will not lead to a long-term infection, like being infected with the virus itself, and it cannot be passed on to others. So this single-round disabled virus, we call it, was tested in women aged 16 to 35 that were previously seronegative. And then being a phase 2 study, it was a small test of whether there was any impact on who got CMV after that vaccine. This vaccine didn't quite reach the protection that they were looking for against acquiring the infection after the vaccine. So it may be going back to the drawing board before coming back, but it was very safe, which was good news as well. The other is in a phase 1 study, and there are actually a number in a phase 1 study, but one example is subunit vaccines. So these are the sort of one of our oldest types of vaccines called protein vaccines that are similar to that of our hepatitis B vaccine, as an example. This is a vaccine that has 2 components of the virus, again, that glycoprotein B and pentameric complex, with an adjuvant that's been used in other vaccines to test the safety of that vaccine. all of the vaccines that have been tested have been safe and have not had any ill effects that have led to taking them out of trials. So we have a number of what seem to be safe products coming to testing around if they're good enough to prevent CMV acquisition to then move into use across the populations.
Oh, that sounds exciting. So, not to leave you out, Amanda. So, what is known about how providers can help increase confidence in vaccines among their patients? We know that people like to hear from their doctors.
Yeah, I think that that's one of the biggest things is provider recommendation, right? People go to providers that they trust. And so that's really important for people. And I think people have very legitimate, concerns, and they're coming from a really good place. They want to make sure that something that they're taking is safe for them, safe for their baby. And so there are some reasons why people are hesitant, and sometimes there's misinformation. And so I think that it's really important for providers to take the time to acknowledge their concerns, not dismiss those concerns right away, but provide the factual information about how these products are tested, how safe they are, how they work, and really what are the things that you're going to be able to avoid by taking the vaccine. I think with CMV in particular, another thing that's really important is, like we looked at earlier, only 9% of women have even heard of CMV. And so if you've never heard of something, if your doctor comes to you and says, oh, here's this vaccine you need to take for something you've never heard of, you might think, well, I don't really need that. And so I think it's going to be really important for people to talk to their providers and for them to understand what the risk of CMV even is without a vaccine, because it's one of the most common things that can harm a pregnancy. And then, of course, we know that removing barriers is really important as well. So making vaccines available, affordable, accessible, providing information in different languages for people who need it, so that they're able to access the information in a way that makes sense to them. All those things are really important too.
Right. So, we touched a little bit on what clinicians will need to advocate, but comment a little bit more about what's going to be needed, Amanda.
Yeah, so
I'm looking at this slide thinking we kind of touched on this, but we really didn't yet.
We talked a little bit about this, but people want access to the information. They want to know how long the product was tested, how safe it is, how well it works. Is it even going to make a difference? And then, like we talked about too, people just need to know a little bit more about CMV to begin with. And I think Sallie can talk a little bit about this too. But right now, we're not screening every baby, so it can feel like this isn't that common, even though it is. And so people are going to need information about all those things.
Right. And we have a few minutes. So, Sallie, I'm going to just throw something out. You didn't expect this, but talk a little bit about universal screening. Like, what are we talking about? Because I think we're talking about a vaccine, but like, there's probably people on this call who are going, yeah, but I've never heard of this, or I've kind of heard about it, but it must not be important because babies aren't screened for it. So what's kind of happening with screening and babies right now?
Yeah, that's also an area that's on the move, and I think something we're going to see a lot of changes coming at the local, state, and national level, where it's now pretty clear from studies that it is both cost beneficial and health beneficial for every baby to be screened at birth for this very common infection that doesn't always have all its symptoms presented at birth. There is the risk that those children will go on to have development of hearing loss or develop developmental delays or other learning or achieving their milestones issues, that if you know to look out for those, we're much better equipped to address them early rather than let them persist and then have more impacts. So there is a clear benefit to testing every baby at birth. The type of test to be used has been kind of where the field has been stuck. You know this well, is the blood test, the newborn blood test that is used for all newborn screening we do now. When it's been studied for this infection, it doesn't achieve the same high sensitivity that you would look for in all the genetic screening tests or other screening tests that we do. But it's been getting a bit better over time. So that's being implemented in some regions. Then the other type of test would be a saliva or urine test, which has much more sensitivity, but a little harder to get, not something we get on every baby now. So states, one by one, are really coming to legislation around their approach to the CMV screening. There are many states that have reflexive screening. If you have hearing loss diagnosed at birth, you need a test. But really, what we're seeing now is states start to take on universal testing. There are 2 states now doing universal testing, Minnesota and New York, not the state that I'm in. But even that we're going to learn from. They're more sort of our implementation bellwethers that I think then will guide the rest of the country. But there is, movement on a national level to identify funding that can support these programs. So I think the testing will only increase, which will only increase the awareness, which is really what's going to be needed to make sure that this vaccine gets to all the people who need it.
Right. And I think Amanda in Connecticut coming on in 2025.
Yes, it should be next year. Yep.
Yeah. So they're coming on. And then if you live in Canada, Ontario is happening and a couple other provinces. So there, just so if you're not in one of those states, there are other states that are doing what Sallie mentioned, the targeted screening or focusing if a child doesn't pass their newborn hearing screening. So that's happening. But going on, I'm going to jump back to you, Amanda, because I know your daughter was born with congenital CMV, and I would really like for you to talk to us a little bit about what would you have done differently if you'd known about congenital CMV, but also kind of her journey, and or even other parents and their journeys. I think a lot of people don't know what that means for a family and for a child.
Yeah, for sure. So our story is a little unique in that we did get the diagnosis during pregnancy, and most people don't. So in some ways that was a good thing, because that really allowed us to do a lot of research, get the information, get the best available treatment at the time. We got experimental treatment during pregnancy, and then when she was born, we were able to access early intervention services right away. And we were able to access antivirals right away because she was born symptomatic. My daughter, I did have a primary infection during the first trimester, so she is more severely impacted than a lot of the children. So in some ways, that's very unique. But she had those advantages, so that was really important for us. So really, when I think about what I would have done differently, it really is taking some steps to try to prevent catching the virus. I did have a toddler at home at the time. He also went to daycare. And so I did some things that in retrospect, I could have easily changed had I known that I was putting myself and my baby at risk. Just one example, I always think about that, he was a little picky toddler and he'd eat half of his breakfast. And I was just trying to be a good steward and not throw away perfectly good food. And I would just finish the rest of his breakfast. And I had no idea that was really putting my pregnancy and my, at risk. And so that's what I would change. I think a lot of our families feel that way. I do think a lot of our families also would like to get the diagnosis in a more timely manner after birth, because a lot of our families are searching and they go on a diagnostic odyssey to try to figure out what's causing the issues that their child has. And so knowing that this diagnosis needs to come from a sample taken within the first 3 weeks of life, our families would like to get this information sooner so that they can monitor and intervene if needed.
Right. I think, when a neonatologist walks in the door or a pediatrician and says your baby has CMV, and you're like, what is that? And then that's, at least the baby gets tested right then, because even though we just talked about universal screening, it's not really, happening everywhere. And so most babies aren't. But I've heard a lot of stories, like you said, of trying to figure out why the child has hearing loss, or what's going on, why is this happening, and many times didn't receive a diagnosis until later, and that's a lot of stress on a family, I would think. And so, yeah, I mean, so we've heard the stories and different things, and it's just it's something we need to keep making ourselves aware, as well as the healthcare providers and also mothers and parents, because like you said, we're trying, if a mother got a message to avoid saliva and urine while pregnant, I think most pregnant women would say, I can do that. I mean, you avoid cheese, you avoid cat litter, right? mosquitoes. So it's something that, I mean, it's a little bit harder because your toddler's with you every single day. So you have to make some conscious, awareness, but it is, I think it's doable if you knew that there was a risk. So, yeah. So Sallie, we're getting close to the end. We still have some time. So, what about some closing remarks, and we'll kind of discuss until they kick us off, so we can keep talking about CMV. So any comments you want to add, Sallie?
I was going to say the three of us could talk about CMV probably all day. It's one thing that we all talk about a lot because we've seen how important it is to develop a vaccine and been part of the effort to really develop that vaccine and make people aware. But the just huge benefits we will have if and when, I'm going to say when, we have a vaccine that will be effective in reducing CMV infection during pregnancy and thereby the congenital infection. It is one of the most common reasons a child goes on to not reach their full potential, either because of hearing loss, because of developmental delays, because of a delayed diagnosis, weren't able to get the treatments that might have improved some of those things. And even because of not having universal screening, we haven't seen all of the impacts fully elucidated. Like Amanda talked about, autism now being associated with CMV. Another one that I talk about and think about a lot is leukemia. Childhood leukemia is being associated with congenital CMV. So there's a lot of things that actually might go away that haven't even fully been tied to CMV that we may see once we have an effective vaccine. But surely we have all seen the families that are affected, the children that deserve to be born healthy, really, and had some of their potential taken from them because of an infection that we don't have good prevention for, we don't have good treatment for. And if you think about how quickly we made a vaccine for COVID, for a brand new infection, 60 years is enough. I think enough time where even the most complex viruses, and this is one, it is a very complex virus to vaccinate against, but it is beyond time for us to have this vaccine and to provide mothers, families, babies, and really the globe with a healthier outlook for all children that are born.
Right. And I think, we talked about, preventing it through behavioral, but really the key is a vaccine, because we all know behavior, we slip up on our behaviors, right? So it would be better if it could be a vaccine that we'd have available. So I think it's exciting times ahead of us and an opportunity. And just in closing, is there anything else that we could probably discuss, but I don't want us to close before we're finished with at least this topic. And so, Amanda, any final words or comments?
I would just say, yeah, like you guys, I'm just thrilled that it feels like we're getting closer. And I think that I can speak for all the CMV families that have been impacted in saying that, yes, we agree with Sallie. It's high time for this to happen. And I just think that the burden on families is huge. So we're just so excited to be a part of this time. And we're hoping that it's going to be very soon that we see a licensed vaccine.
Right. Yeah. And so anything else? I'm going to give you one last chance, Sallie. You're my expert, so I'm counting on you.
My comment will be to tell your friends, tell your colleagues, tell people on the street about that this virus is a problem. We need a vaccine for it. Women who are pregnant should know about it. And that is for the sake of our children. And we need to invest early in health so we can have a healthier society. And this is one way we will do that. So tell everyone about it.
Yes, great. So Sallie and Amanda, thank you so much. This has been a great discussion, and I always love talking with you guys. So maybe we can do it again. Thanks.
Sounds good. Thanks.
Karen. Thank you.